Amenorrhea serves as a vital alarm bell indicating that a highly calibrated physiological communication chain has broken down. In clinical practice, this breakdown is classified into two distinct categories. The first is primary amenorrhea, which describes a young patient, typically around 18 years old, who has gone through an apparently normal puberty but has never experienced menarche, her first menstrual period. The second category is secondary amenorrhea. This applies to a woman who previously had regular or irregular menstrual cycles, but has now experienced a cessation of menses for greater than 6 months. Accurately diagnosing the root cause requires the clinician to systematically separate structural, anatomical blockages from chemical, hormonal signaling failures. Normal menstruation relies on the hypothalamic pituitary ovarian axis, or HPO axis. This is a tightly regulated hormonal feedback loop that sends chemical signals from the brain down to the ovaries, ultimately stimulating an intact uterus. Rapid clinical assessment requires identifying exactly where this specific axis breaks. Modern clinical guidelines, including those from the Australian Medical Council, focus purely on direct hormonal assays and anatomical imaging to determine the etiology. This direct approach bypasses legacy diagnostic steps like the progestin challenge. Every potential cause of amenorrhea can ultimately be mapped to a physical or endocrine failure at one of these four specific anatomical nodes: the hypothalamus, the pituitary, the ovaries, or the uterus. Primary amenorrhea can be elegantly stratified without immediate lab tests by looking at two visible physical milestones. This is a 2x2 grid sorting these physical markers. The x-axis represents the presence or absence of breast development. This acts as a reliable clinical proxy for active estrogen production. The y-axis tracks the presence or absence of a uterus. This confirms proper Müllerian duct development. The Müllerian ducts are embryological structures that develop into the female reproductive tract. In the top left positive quadrant, both anatomy and hormones are present. This points directly to structural outflow obstructions, such as an imperforate hymen or a transverse vaginal septum. The system is working, but the blood is physically blocked. In the top right positive quadrant, the patient produces hormones but lacks Müllerian structures. This requires a differential diagnosis between Müllerian agenesis and androgen insensitivity syndrome. Observing these two physical traits instantly isolates whether the core problem is a structural plumbing issue or a chemical software defect. Moving to the negative-positive quadrant, we find sexually infantile presentations. Here, the uterine plumbing exists, but the hormonal drive is completely absent. Turner syndrome is the primary cause for patients in this category, who present with short stature and streak gonads. Streak gonads are non-functioning, fibrotic strips of ovarian tissue that fail to produce hormones. This illustration highlights the classic phenotypic markers of Turner syndrome: a webbed neck from a cystic hygroma, a wide carrying angle of the arms, and cardiovascular anomalies like coarctation of the aorta. Coarctation is a localized narrowing of the main artery carrying blood away from the heart. Contrast this with Kalman syndrome. These patients have a normal stature, but present with a lack of hormonal drive paired with anosmia, a lack of smell, and colorblindness. Recognizing these specific phenotypic profiles allow clinicians to bypass unnecessary testing and immediately pinpoint the genetic or hypothalamic root cause of the missing hormonal drive. When evaluating secondary amenorrhea, the absolute first critical rule-out before beginning any complex endocrine workup is checking for pregnancy and menopause. Once those are excluded, we use a top-down failure model. Starting at the highest level, the hypothalamus, we look for external factors: emotional stress, eating disorders like anorexia or bulimia, and extreme exercise can halt signaling right at the source. Moving one step down to the pituitary level, microadenomas are the most common tumor cause of amenorrhea here, specifically prolactinomas. A prolactinoma is a benign tumor of the pituitary gland that secretes excess prolactin, suppressing normal menstrual cycles. Another major pituitary cause is Sheehan syndrome. This is a specific necrosis of the anterior pituitary caused by severe postpartum hemorrhage and the resulting hypovolemic shock. The classic triad of symptoms indicating Sheehan's includes agalactorrhea, hypothyroidism, and adrenal insufficiency. Agalactorrhea is the inability to produce breast milk after childbirth, a direct result of pituitary tissue death. Evaluating secondary amenorrhea is a strict investigative process of elimination, requiring the clinician to physically trace the endocrine signal pathway from the brain downward. Moving down to the ovarian level, polycystic ovary syndrome, or PCOS, is the most common cause of anovulatory infertility. This chart shows the specific laboratory anomaly that identifies PCOS, a highly elevated luteinizing hormone level relative to follicle-stimulating hormone. Both are glycoproteins that regulate reproductive processes, but in PCOS, they invert from their normal balance to create a 2-to-1 or even 3-to-1 ratio. The physical diagnostic criteria required via ultrasound for PCOS is the presence of greater than 10 cysts on the ovary, alongside normal estrogen levels. Finally, at the uterine level, we find Asherman syndrome. This is defined by the presence of severe intrauterine adhesions and scarring. The classic patient history that points to Asherman's is a patient presenting with amenorrhea following a DNC procedure for an abortion or incomplete miscarriage. A DNC is dilation and curettage, a surgical procedure to scrape and clear the uterine lining. Identifying the exact anatomical failure point dictates the entirety of the treatment plan, whether that means shrinking of the pituitary tumor, resolving an ovarian hormone imbalance, or surgically removing uterine scars. Transitioning from theoretical pathology to the practical clinical diagnostic workflow ensures no steps are missed when a patient presents with secondary amenorrhea. Step 1. The clinician must always perform a spot urinary pregnancy test to definitively confirm or exclude a progressing pregnancy. This is done by testing for beta-HCG, the human chorionic gonadotropin hormone produced during early pregnancy. Step 2. If the pregnancy test is negative, the clinician must order a specific hormonal blood panel consisting of FSH, LH, prolactin, estradiol, and TFTs. TFTs are thyroid function tests, which measure the performance of the thyroid gland to rule out systemic metabolic interference. Adhering to this standardized stepwise approach prevents premature diagnostic anchoring and ensures systemic causes, like underlying thyroid dysfunction, are captured immediately. The workup rules shift significantly for a young patient, such as an 18-year-old, presenting with primary amenorrhea. The Australian Medical Council defines an absolute critical error in these cases. A clinician must never perform a pelvic vaginal examination on a virginal patient. Violating this rule or even requesting the exam in an OSC scenario is considered a significant, potentially failing error. An OSC is an objective, structured clinical examination, the standard practical assessment used to test the clinical skill performance of medical students and doctors. The correct anatomical assessment tool is an abdominal pelvic ultrasound, not a vaginal ultrasound. This is ordered to verify the proper development of the uterus and vagina. This non-invasive ultrasound is followed by the standard hormonal panel of FSH, LH, prolactin, and estradiol. Chromosome analysis is only necessary if these initial tests return abnormal. The principle of first do no harm applies directly to diagnostic sequencing. Non-invasive imaging provides all the necessary structural data without subjecting the young patient to unnecessary trauma. To evaluate primary amenorrhea, utilize the breast and uterus 2x2 matrix to categorize the pathology and confirm the patient's internal anatomy strictly with an abdominal ultrasound. For secondary amenorrhea, rule out pregnancy with a beta-HCG test first, then trace the failure from the top down through the hypothalamus, pituitary, ovary, and uterus. By systematically combining physical markers, non-invasive imaging, and targeted hormone panels, clinicians can deduce the exact physiological breakdown from first principles, rather than relying on rote memorization.